Is my audio still coming through okay, Sean?
All right, hopefully everybody can hear us now.
Can you hear me okay, Sean?
Yep, I hear you. All right, so I guess I'll be the presenter. You should bring your presentation up now.
Is it still showing?
Not showing yet.
Oh, show my screen again?
Yeah.
Okay,
There you go.
excellent. I hope it changed.
Did you try to advance your slide yet?
Yeah, does it move?
I don't see it moving.
Uh-oh.
Is it? But it's Liz said it's moving on hers, so we're good.
Oh, it's moving? Okay.
All right. Well, real quick before Curtis gets started, a couple of items I'll go through for everybody. So first things to do here for our 9th annual conference. Curtis, I'm going to mute you for just a second. Make sure, if you haven't already, that you've registered for each session that you wish to attend. If you registered for just this session, this is the only session you will get. Everyone will be muted. It's actually not actually an option for you to be unmuted or to show yourself. So sorry. If you have any questions, please type them in the chat and we will ask those. We don't have a way to send out any course completion certificates for anybody who didn't register themselves individually. We don't have a way to track who was or wasn't there. So for that, please create your own roster for your agency and keep track of it that way. For those who do register and sign in, your certificate of attendance will come out an hour after this is over. It's automatically sent at that point. We will also take all those recorded sessions and share them to our YouTube page, so you can watch them later if you so desire. And again, any questions you have, please type them in the chat. We will monitor that as we go through. So with that being said, Curtis, I will turn it over to you.
Great. Thanks a lot, Sean. Hopefully you can all still hear me. Greetings from wherever you happen to be today, and I hope that you are surviving the cold and the snow and everything else that's going on here in our beautiful state. It's beautiful here in Portland today, but it is pretty chilly. Thanks again to the organizers for asking me to do this. I always enjoy doing this conference. We'll go ahead and get started. For those of you that don't know me, my name is Curtis Ryan. I'm a registered nurse at the Oregon Burn Center. I've been around the Burn Center for quite a few years, and I'm the outreach education coordinator. And I come out and do classes for all of you guys and gals out there in the EMS world and hospital world on burn care and burn prevention. So today's talk will be on pediatric burns, trying to talk about the difference between kids and adults when it comes to burn injuries, and what to be aware of for child abuse. We'll go through all of this stuff here as we go through the talk. Like Sean said, if you have any questions, please put it in the chat, and I guess we'll all be monitoring that to make sure we get your questions answered for you. So that switch for me, Sean, I hope. Just to let you know, I have nothing. It did. Okay, good. Just to let you know, I have nothing to disclose. I'm not associated with any companies that provide anything for the burn center and stuff, because if I did, I'd be living in a much more expensive house and up on a hill somewhere. Just, you know, that's the way it is. So what are our objectives here for this? Well, we're going to look at what the initial evaluation of a pediatric burn victim is, because sometimes it does differ from an adult. How do you estimate the surface area involved? Because rules of 9 can be a bit misleading when it comes to kids. We'll look at the different depths of burn injury, because there are some that are treated differently than others when it comes to fluid resuscitation and topicals. We'll look at the referral criteria from the American Burn Association for referring to a burn unit. And unfortunately, we'll also be looking at assess the potential for child abuse, which does happen quite a bit in the burn world. So we'll look at some epidemiology and outcomes, conditional and primary and secondary evaluation, height, size, and depth of burns, resuscitation, wound care, all the basic stuff that we want to be dealing with burns in the pediatric population. So how do kids differ from adults? Well, they have a larger body surface area in relationship to body weight. Their skin thickness is different. They regulate their temperature differently. We all know that kids under the age of 1 can't shiver, so they have to be bundled up in blankets and whatnot to stay warm. So they rely on us for their temperature regulation. Their airways are different. The estimation of burn size is a little bit different. Their fluid resuscitation calculations are different. We don't just use Parkland formula as a general resuscitation anymore. And there's also that category of non-accidental injury that we'll get into later on. So when it comes to body surface area, how do they differ? Well, they have a higher body surface area to weight ratio. So a 7-kilo kid, that's it's 10% of an average weight of an adult. That's at 70 kilograms, but they have 33% more of the body surface area as that adult. So less weight in proportion to body surface area, if that makes sense. But I'm not confusing people here with talking about that part of it. They have thinner skin. I always tell people we start out in diapers and thin skin, and we end up in diapers and thin skin. I'm getting closer to that other end of the spectrum every day myself. I'm 63, so sooner or later I will be back to that super thin skin and be wearing diapers again here fairly soon, I think. They will get a full thickness burn where an adult would only be a partial thickness type injury, and sometimes it's hard to tell. Scald burns can be lobster red, and that lobster red can be indicative of a full thickness scald burn. So if it looks like it's partial thickness on a kid, it might actually be a full thickness injury. Because of their body surface area to weight ratio, they have more body surface area exposed to the atmosphere, so they get more hypothermic more quickly than an adult. And the third leading cause of death for a burn victim is hypothermia. We had a patient just within the last month that came to us from another country because he had family here in the Pacific Northwest, who showed up at about 30 degrees Celsius, and he actually went into cardiac arrest related to the hypothermia. So that's why we always stress, keep your patients clean, warm, and dry. If you're in an area with a burn victim and the temperature to you is comfortable, it's too cold, plain and simple. If you can remember that, just have the back of your ambulances, have the heat cranked up, or if you're in a room with a burn patient, whatever, just get the heat cranked up as much as you can. This comes from the National Burn Registry, where we keep data from burn centers across the United States. We contribute to this. And you'll notice that light blue line is indicative of scald burns. And you can see that between 0 and 5, the scald burns are the highest rate of type of injuries that we get in our lifetime. So kids are more susceptible to scalds. And the darker sort of greenish, sort of bluish, I'm kind of sort of gray-green blue line is contact injury. Those are also high. But then when we get to the age of 5, you notice that that orange line and the dark and the light blue line start going away, and the flame injury, that grayish green line, sort of starts popping in, and then it comes across. So flame injuries become more prevalent after the age of 5. So we really stress kitchen safety and scald prevention in children under the age of 5. Just recently we had National Burn Awareness Week, and National Burn Awareness Week was all about kitchen safety. And there's a lot of stuff on the American Burn Association website that you can go to that has a lot of things that we've created to help you keep your children and your family safe in the kitchen. This stat I threw in here because of COVID. For the last 2 years, we have lived in the COVID world. And from March of 2019 to September of 2020, there was a 32.5% increase of unintentional burn injuries in children. The greatest number of that happened in July of 2020, around the 4th of July, obviously, because kids were out playing around. But the increase, they think, was because we had more children at home that weren't in school, more parents at home. People were more stressed. They weren't as careful. And we saw a larger increase in burn injuries during that time. But then come to 2021, at least the statistics I've seen at the Oregon Burn Center, the numbers started going back down again because people got more used to being safer in the house because they were more used to being stuck at home and had learned to put up prevention efforts and stuff to keep their children from getting burned. So in your initial evaluation, the first thing you want to remember is forget the skin. Don't get distracted by the burn. It's easy to do. Even at the burn center, we get distracted by the skin. we look at the burn, we don't look at everything else. And the main thing to remember is trauma always takes priority over burn. If a person's got a piece of big old rebar through their head, that's going to kill them before the burn does. A patient in shock is going to die from shock before they die from the burn. So don't get overwhelmed by that look and the smell and everything of the burn. You want to just go head to toe. Do what you always do for your primary and secondary survey, and try and just not look at the skin all the time. And in your primary survey, it's just like everything else. It's A through E, and we're going to go through it as far as we would do for what we would do for any trauma or burn, but we're going to look at it as according to burns and as it relates to pediatrics. So in your initial evaluation, your airway, you're going to evaluate the airway. You're going to control for anybody who's unstable, for an inhalation injury, for large burns, and with kids, especially you want to go with the large burns because they're getting that fluid resuscitation, and large fluid resuscitation can also indicate that you might need to get an airway in them because of the swelling. You want to protect their cervical spine, especially if there's a trauma involved. Oral tracheal intubation is preferred. I don't remember the last time I saw anybody nasally intubated. I just don't think that's even really done anymore unless it's for specific type of injuries to the, to the airway or whatever. And we like you to use the larger appropriate tube for intubating that you can, because we sometimes need to get down in there with a bronchoscope and look at the lower airways. And we've had cases where the tube that was placed was too small for the bronchoscope, and the bronchoscope actually gets kind of stuck. So go with the larger appropriate airway if you can. Start with 100% oxygen. Non-rebreather at 15 liters delivers 100% oxygen. You can treat CO poisoning with 100% oxygen. You can help treat cyanide poisoning with 100% oxygen. It really does a lot for a burn patient. Constantly reassess that airway to make sure that it's not gone down the right main stem, make sure that you're not down the esophagus, make sure it's in the right spot, and you're ventilating both sides of that field. Intubate as necessary prior to transport. We do have intubation triage protocols at the burn center that we can share with you guys that tells you if this, then that sort of thing when it comes to intubating patients. But if somebody's, we want you to treat the symptoms and not the signs. If somebody's got soot on their face, but they're sitting fine, they're talking fine, they're breathing fine, they need to be watched, but not necessarily intubated. But if they're hypoxic, if they're hoarse or they're stridorous, they're having trouble breathing, they have soot in their oral pharynx, things like that, those are the signs that we look for to intubate a patient. We will not fault you for intubating anybody. We can always take the tube out, but we will fault people if they accidentally go down the esophagus, which is rare, but it does happen. And with kids, the proper tube size, if you don't have anything else to measure it with, the size of the little finger is a good indicator for tube size. Just go with that and get them intubated and get that airway open. They have difference in their anatomy from an adult. So their larynx is more forward. Their glottis is angled more acutely than in an adult. It's more towards the front than it is an adult. The narrowest point in a kid is their crank, not their glottis, so it's kind of opposite from an adult. You can gauge the tube size, like I said, by their small finger, the outside diameter inside of their nares. Powell's formula, if you've taken Powell's, there's other formulas out there also. Broslow tape is a really good way to do it. They're all guidelines. I always use Shaquille O'Neal as my example here. When he was in the 6th grade, he was 6'6", right? He was also 18 years old, but that's a whole nother lecture that I do. But Broslow tape wouldn't work for that kid because that kid is already beyond the limits of the Broslow tape. We also recommend an NG tube on kids, and anybody with over 20% deep burn, an NG tube is a good idea. But kids like to swallow air, so it's a good idea to have an NG tube in there for decompression if it's indicated. So, ET tube indication in kids and infants if they have significant respiratory distress. If their upper airway is compromised by edema, which can also be caused, like I said, from a large body surface area that's burned, and you're giving large volume of fluid resuscitation, these kids will puff up quicker than an adult, and the airways are so small they'll lose those airways quicker than an adult. So you got to really be aware of that to get them intubated to make sure that that edema doesn't affect their airway. So get those tubes in there to keep those things protected. With breathing, listen. You have both fields going. You only have one side that you can hear air on, and the trach is deviated, so you might have a tension pneumothorax. So you got to look at it. You got to listen to things. Make sure it's in the right spot. Get the high flow oxygen going. With CO poisoning, high flow O2 will decrease their chances of will decrease CO poisoning by half in an hour, 4 hours on room air. Look at the quality and depth of their breathing. Somebody with a circumferential burn around their chest or abdomen, it squeezes it in and it compromises their ability to breathe. So when they get to us, we may have to do escharotomies to relieve that pressure through the eschar, through the burn tissue that's causing that constriction around the chest and abdomen. So look to see if they're breathing deep, if the quality of their breaths are good. And if they're not, you need to let us know before they get there so we can have everything set up for doing their escharotomies. Oh, and by the way, the reason I don't have my camera turned on is I'm in my basement and it looks like I'm sitting in a storage locker right now. So I didn't want you to see all the crap sitting behind me here in my basement. It's, you know, it's kind of like my storage locker anyway. Circulation. We evaluate circulation through blood pressure and pulse, plain and simple. Are any of the crews out there right now, do any of you happen to be carrying Dopplers on your rigs? Is that something that's happening or not? Sean, can you answer that for me or anybody out there?
No, we used to back in the day for blood pressure issues, but not so much for Dopplers. But now what some might have is the nice Littman echoes, which is good.
Okay. Because if you can't feel a pulse, you can always elevate their extremity to get the pulse back. But we use Dopplers. If we lose a pulse, we get out a Doppler. We listen for the pulse. We track palmar arch because we might be able to hear them in the radial ulnar, but we still want to listen to see if it's in the palmar arch also. If not, then we're starting to consider escharotomies again on extremities. So Dopplers are kind of a good thing for us to use. And I do know that I've talked to a few people in EMS that do carry them. I think I don't know if they're on their rigs or if they're just something they happen to carry. Blood pressure may not be accurate, but it's a good baseline for you to measure so you can get that initial blood pressure, and if things are going up or down, you know what's happening. You kind of get a feel for what's happening with that blood pressure. If a patient is alert and oriented, all burn patients should be alert and oriented. If they're not, there's a reason why they're not. Do they have an associated injury? Did they get a head injury and did they fall down trying to get out of the house in the fire? Have they sucked in too much carbon monoxide or are they hypoxic? Substance abuse, and you're thinking, well, this is a pediatric talk. Why are we talking about substance abuse? Well, because we have had children that have come in positive for drugs because their parents are positive for drugs and the kids have gotten into something. And with teenagers, there's always that chance. Or do they have a pre-existing medical condition that causes them to be not alert and oriented? If a burn patient has a decreased level of consciousness, one of the simple things you can check is a blood sugar. Especially in little kids, you might find out if it could be a sugar problem that's causing them to have that level of consciousness that's not up to where it should be. Get all their clothing and jewelry off and keep them clean, warm, and dry. That is extremely important. We have patients coming to us that are packed in ice, that have wet sheets on them. No, just clean, dry blankets or sheets or a sleeping bag or a coat or a solar blanket or saran wrap, anything you can put over the top of it to help hold the heat in will work. It does not have to be sterile. Are the blue burn sheets still standard on most ambulances? I don't know. Is that still something that ambulances carry on a regular basis?
I think it would depend on the agency. Some do those, some are just clean sheets.
Okay, yeah, because I think if you've ever used those burn blankets, they tend to kind of disintegrate on you when they get wet and they fall apart and you got stuff laying all over the place. But if that's all you got, use it. but just get some, sheets on there. Warm the IV fluids if you need to. There's all sorts of different ways to keep patients warm on transport, but just clean, warm, and dry is the basic key to a burn survival for a burn patient. After you've got your resuscitation efforts going, you do your head to toe. Where did it happen? How did it happen? Was it inside or outside? What type of mechanism? Was it electrical? Was it flame? Was it a scald? Was it chemical? Try and get a history and do a good physical exam. My slides keep changing on me for some reason. And if it's a little kid, of course, you're going to get that history from the family. Get as much information as you can from the patient and the family. I think all of our agencies out there, you all know the mnemonic sample for doing your history on your patients. But remember, and this is really important, and you're going to laugh at me for saying this, but it has happened more than once. Get that history on the patients before you intubate them. Because once they're intubated, you can't get anything from them, especially, older kids who are teenagers and stuff that might be able to tell you something. But get as much information as you can from the patient, and probably mostly you're going to be getting it from the family when it comes to pediatrics. Scalds, like I showed you earlier, count for a huge percentage of pediatric burns, especially in kids under the age of 5. That's the most common type of injury. In the burn center, we see about 400 plus patients a year in the burn center, and a third of them are kids, and most of them are under the age of 5. So tap water, hot foods, hot beverages, kids pulling stuff out of a microwave. This picture of this little one here reaching up to the stove. And unfortunately, scalds are also very prevalent in child abuse. People use hot water to punish kids. They won't stop crying, so they stick them in hot water. They pooped in their diapers, so they stick them in hot water. I've seen kids die from being stuck in hot water intentionally. And you'll see different signs, and we'll talk about what to look for when it comes to the signs you need to look for child abuse. This little guy here, 7 months old, is getting a bath in the kitchen sink. And mom said that he moved, and when he moved, she reached across him to grab him. And when she did, she hit the water controller, and it went all the way over to hot. Can you see my cursor on the screen here, Sean?
Yep.
Okay, so the water came in on the top of his thigh here and ran down behind his leg and around his butt. This is a deep burn on this little guy. Now, if you try pushing on this, it may or may not blanch. If it doesn't blanch, that's a full thickness scald burn. And in this picture here, we saw something that made us report this as suspected child abuse. And the reason we did that was we saw burn here on the abdomen, and we saw burn on the thigh, but you see this area right here that's not burned? We call that a spared space. If a kid knows they're going to get dipped in hot water, one of the things they do to protect themselves is they fold up into a ball, like a little potato bud. And they get skin-to-skin contact, and when that happens, the water can't get in there, and you have a spared space. So we reported it, but it wasn't child abuse. When they got out to the house, they realized it was kind of a big kid sitting in a small sink, so he was already setting with his leg up against his abdomen. But they checked their hot water heater while they were there, and the hot water heater was malfunctioning, and the temperature of the water coming out of the hot water heater was 186 degrees. So always make sure your hot water heaters are set at 120 degrees. No more, no less. If they're more, they can cause major problems. If they're less, there are some bacteria that will grow in warm water, like Legionella. And Shriners recommends little ones, if you're giving them a bath, after you put the water in their bassinet or what in their little bathtub thing you use. It's been a while since I've had kids. Check the water and make sure that it's not over 100 degrees. And that's a recommendation from Shriners. So this was not an intentional injury, but it is a bad, bad scald injury on this little guy. Flame burns in kids are the second most common type of injury. And you'll notice we have a picture of a lighter and matches here because kids get a hold of these and play with them and will start a fire, especially if they're unattended. It's the most common in kids over the age of 5. And the things that we see with it are inhalation injuries, which only about 10 to 20% of the people in a burn unit have an inhalation injury. but they account for 60 to 70% of the deaths. So an inhalation injury decreases your chance of survival. Carbon monoxide poisoning, odorless, colorless gas, incomplete combustion. It's always there. As firefighters and stuff, you know that there's always some form of carbon monoxide. There's also other chemicals. Now with cyanide, if you do carry a cyano kit, there are special times when you do and don't give a cyano kit. And if you do give a cyano kit, let us know, because it changes the color of their blood, their urine, to bright red. It looks like blood in their urine. And it also changes the color of their blood, and it throws off their labs for about a week. So we need to know that you use the cyano kit if you do. And there's also associated trauma from kids trying to get out of a burning building. So these are all the things with flame burns that can be associated. How many people, I don't know if you remember this, Sean, when they had the Judy Okulich used to be at the Oregon State Fire Marshal's office and started this campaign to get rid of lighters that looked like toys. And Oregon was the spearhead for that, because there were lighters that looked like trucks and dogs and cars, and kids would play with them, catch and get things on fire. And it took a long time to get them off the market, because it was really hard to get it passed through our legislatures across the United States to ban them. And the way they finally got them banned was they proved that the paint on the lighters had lead in it. And that's what got them banned. It wasn't the fact that kids were catching on fire, it was the fact that there was lead in the paint. So thank God we got those things off the market. This little guy was playing with matches. The parents went to jail for child neglect, because in Oregon, you can't leave a kid at home by themselves until they're 10, and this kid is 6. He caught his shirt on fire. The neighbors saw the flames and the smoke and got the kid out. So he's got a burning shirt on inside of a burning house. What would be my very first concern with this kid being inside of a smoke-filled room with a burning shirt on? Well, smoke inhalation, plain and simple. And if he's wearing now, since we're doing the Eastern Oregon AMS conference, I'm sitting here wearing a Pendleton shirt because I love my Pendleton shirts. If my Pendleton shirt caught on fire, once again, I need to worry about cyanide, because that's a byproduct of burning wool. So if you're ever in a field full of burning sheep, just run. Get out of there as fast as you can. Get away from the burning sheep so you don't get cyanide poisoning. But this is a lifetime for this little guy with all these scars. This is a full thickness injury. This required a lot of skin grafting and a lot of physical and occupational therapy to make sure he didn't have scar contractures right here in his axilla from that burn. Another thing little kids do is they touch things that are hot. Contact burns, hot stoves, barbecues, fireplace rings when you're camping. They get really bad burns because sometimes their hands will stick to that stuff and they can't get it off. So they have a prolonged exposure to it, and they get these really nasty burns. Now here is a kid who touched a glass-fronted gas fireplace. Those things get super, super hot. The prevention committee I'm on at the American Burn Association, we got the industry to put up, if you've ever put in a new gas fireplace, like my wife and I did, it comes with a screen that sets just a couple inches away from the glass to protect little hands from touching the glass. That's why those screens are there. It's not retroactive, but the new ones have to have that. But if you do see a palmer or a planter blister like this, you will want to drain it, but don't debride it. Leave it intact. If you drain blisters, leave them intact, especially plantar and palmar surface areas. You leave those blisters intact. Chemical burns. Kids get into chemicals, they swallow them, they pour them on themselves. It's mostly household products like cleaners and whatnot. This picture here, this was a little 2-year-old girl who sat in liquid Drano for 15 minutes because she poured it on herself. Babysitter went to jail for child neglect because she wasn't watching the kids at the daycare. We flushed her for 3 hours at the burn unit to get that chemical to as close to zero as concentration as we could, and to get the pH down. Sorry, I'm coughing my brains out here. And to get the pH as close to normal as possible. Everything you start with flushing with water. But remember, like I said, you don't want to get them too cold. So with any type of burn, if they're still burning, if they're warm, they're still burning. But never use ice on a burn because it can cause frostbite or cause a burn to convert to a deeper burn. But this is where you go, and we do it for 5 minutes, cool but not ice cold water for 5 minutes to stop the burning process. When it comes to chemicals, though, you go beyond 5 minutes. We tell lay people you flush until the pain goes away or medical help arrives. And with you folks, we want you to keep flushing. We want you to contact Poison Control or Hazmat. They have all the answers to that stuff. I have an app on my phone called Wiser. I'm sure some of you do too, WISER, that tells you how to treat all these chemicals. It's not a definitive source, but it gives you a starting point. There's very few things that you don't want to use water on. But flush, flush, flush. We saved her legs, and she's like 20 years old now, and she's doing fine. But each chemical does something different. Organics mess with the fatty tissue. Acids cause coagulation necrosis. They form an escarine. They don't get in deep. And alkali burns get in really deep and do a lot of damage. With electrical burns, we call them the grand masquerader because you can't see some of the damage because it's hidden. But with kids, it's usually because a toddler or a baby is chewing on an electrical cord, or they put an object into a light socket, or you might have a toddler crawling across the floor and you've got a rug with a cord underneath it, and the cord is worn through because of people walking across the rug, and the cord has damaged, and that can happen too. And that can also happen with older folks that run these cords through their houses under their rugs. We don't see it as much as we used to because we've really done a good job of baby proofing houses. And the electrical industry has done a really, really, really good job of making sure that kids don't touch this stuff. So they go out to the schools they teach, and kids get it. We really don't see that many electrical burns with kids. So we don't use first, second, third degree anymore. We just call them superficial, partial thickness, full thickness, and deep into underlying tissue, or fourth degree injury. So a superficial burn, the skin is intact. It's red. It hurts. It blanches when you push on it. The top layer of skin, it heals by itself in 5 to 10 days. It is basically a sunburn. I'm going to tell you this right now. This doesn't count. Never figure a superficial burn into your calculation for fluids because you will over-resuscitate the patient because this is going to fade and go away. So tell them to wear sunblock next time they go outside. Put lotion on their arms when it dries out. Over-the-counter pain meds for the pain. Don't do like Mr. Macho Man did and come into the burn. This is a burn center stretcher. Believe it or not, this guy showed up at the burn unit screaming and yelling about his sunburn and wanted us to treat it. Oh, it hurts so bad. I don't know what I'm gonna do. Oh my God. I think I need some oxycodone. No, you don't, dude. You need Tylenol. Go home. And rehydrate. And this is hard for me to say, but beer doesn't count for rehydration. I know. It's a hard thing to say, especially since I'm a home brewer. But a paramedic pointed out was because of, all the heads of the beer companies got together one day, and the guy from Bud ordered a Bud Light, the guy from Coors ordered a Coors Light, the guy from Miller ordered a Miller Light, and the guy from Guinness ordered a Coke. And they looked at him and said, "Why'd you order a Coke?" And he said, "Well, if the rest of you aren't going to drink beer, neither am I." So that's my beer snob joke for the day. But a paramedic pointed out to me it's because of beer he got burned in the first place. I said, "How do you know that?" He goes, "Well, look, he was wearing a wife beater t-shirt. And he was drinking a can of beer because if you look here, it's not burned because his arm was bent for holding the can of beer." I went, "Yeah. We live in Oregon." And I put my fingers up next to my lips and I said, he might have been standing like this all day. Because, the most commonly heard word in Oregon is the word ear. Think about this. Ear. Somebody said, "You do that really well." I said, "Hey, I've lived in Oregon my whole life. And before I was a nurse, I was a music major." So, I kind of checked off all those boxes. But this just is not going to count as far as burns go. That's our beer sunburn. A partial thickness or second degree burn, it's the top 2 layers of skin. There's blistering, there's swelling, the skin is loose. It feels like it's moving around like it's on ice. It can actually be non-blanching and white, which almost you would consider being a full thickness burn, but where it's here, that's a deep partial thickness burn. This is where we start counting the numbers if it's over 10% of their body surface area, which would be one entire arm and a palm of your hand was 10%. And it looks like this. Now, this little girl here, this is from a deep fat turkey fryer that fell over on a card table and landed on, the oil spilled out onto her. This is full thickness here, or deep partial thickness, and the rest of this is partial thickness. These blisters can be drained. She also had to have kidney dialysis because she got so much muscle damage that her kidneys failed, and we had to put her on continuous dialysis for about 4 weeks until her kidneys kicked back in. But this is a partial and deep partial burn on this little kid right here from hot oil. And oil and tar and hot candle wax, all those things can be considered scald burns just like water because they're liquid in form. A full thickness injury. It's all the way into the sub-Q. This is where you know the difference between it and a partial and a deep partial thickness burn, because not only does it not blanch, it doesn't hurt, and it's dry, and it's leathery, and it's all these different colors depending on the heat source and how long they're exposed to it. And this is a full thickness burn. Now the area around the outside that's just kind of red is going to hurt, but the marbly white, the brown, the yellow, the black, that's all full thickness injury. That's all dead tissue. It's going to have to be removed and skin grafted over the good stuff below it. This is going to, now, these burns here, like this one, lotion, this burn here is going to require a double antibiotic ointment, not triple, because triples have neomycin and people react to neomycin sometimes, and Zeroform to keep her protected. And this burn here is going to require Silvadene cream for treatment and skin grafting, and skin can only come from you to you. And then a 4th degree burn is beyond the skin. It's down into the muscle and the bone. It's charred, it's cracked. Anybody, this is going to sound mean, but anybody who's left like a hot dog on the barbecue for too long knows what they look like when they burn up. That's a 4th degree burn. Now this next picture I'm going to show you, this is only one limb, but this person looks like this from his whole body. 18-year-old kid that's not going to survive was trapped in a burning car. Parents have gotten a call that says, your son's been in a car accident. He's not going to survive. He's at a manual hospital. He's in the Oregon Burn Center. Even if my kids be in their 30s, I can't imagine taking this call. So this is a 4th degree burn. This right here is called an autoesclerotomy. It gets so tight and swells up so much, it just splits open like this. So we make these cuts here to keep that from happening. We dress this with Silvadene and cover it up because the family, the parents, do not need to see this. We've got a line in him, and we're giving him medications to keep him knocked down. So pain meds, Versed, morphine, fentanyl, whatever we want to use, keep him comfortable, because we know he's not going to survive because he's like this from head to toe. There's a patch of skin on the back of the arm over here that wasn't burned, that's fully intact. So when the parents got there, we told them, he will not be respond to you, but we know he can hear you, and there's a patch of skin here that's intact. We know he has feeling there, so for the last 6 hours he was on the planet, the parents knew he could hear them and he could feel them while they told him goodbye. This is still hard to talk about over 20 years later. I remember this. But we had to do that to help with the emotional support for the family. This is where we click into palliative care, comfort care, emotional support, and do everything we can to help the family and friends deal with this situation. And if you're ever involved in a situation like this, we had a crew just last year that was. If you need help with the debriefing, if you need to talk to somebody, if you want to do case studies on things like this to help talk through it, contact us. We're there for you. We're there to help you through it. If you need our assistance, we will be there to help assist you. You just have to call us and let us know. Up to 20% of pediatric burns can be caused by child abuse. So if you think about that, out of every 100 kids, 20 could be child abuse. Most are under the age of 3. Most are scald or contact burns. In my own experience as a nurse, and I don't know if any of the nurses out there in this crowd today, I know that Liz is, some of us can tell you probably the most common thing we've heard when it comes to these stories is the phrase mom's boyfriend. I've heard that way too many times in my own career. Law enforcement should always also be included on your potential abuse calls. When you go out to that call, have law enforcement with you at that call so that they can keep the evidence chain intact, because some people will try and clean things up and destroy evidence. So what do you look for? Well, is the injury inconsistent with the history of the burn? Something doesn't look right. And I'll show you a picture here in a minute of what doesn't look right. Are the burns usually localized in child abuse? They're usually localized to the perineum, the genitals, and the buttocks because of diapers and stuff, where kids have soiled their diapers, soiled their pants, and they get put in hot water for that. The developmental capabilities of the child. You got a 7-month-old who can't walk yet. They're still crawling, but somehow or another they were able to walk in and stand up and pull a pot off the stove. Well, no, the kid's not at a point where he can do that, or she. They can't reach up that high. They're not walking. And so is it something developmentally that they can do? Is there a sock pattern or a glove pattern, which is a line around an ankle or a wrist with no splash marks? Did they delay seeking medical attention? Well, it happened 3 days ago, but I'm just now bringing them in. Does the story change between the adults? One tells you one thing, one tells you something else, and then it changes, and they can't keep it consistent. Are there other injuries that you can see? Cigarette burns, bruising. With our CARES group, and I'm not sure what they use in Eastern Oregon, we use CARES, and there's some people use a thing called CAT, where they'll do skeletal surveys on these kids to see if there's old injuries like old broken ribs and broken bones. Sometimes, if you've been doing this enough, sometimes the hair on the back of your neck just stands up and you just know something's wrong. So you go in there and you have to report this and get this taken. We are required reporters. So here's one that's not consistent with the story. They said it was a curling iron burn. Well, for one, it's on her butt. For two, look where it's at. That's normal. They said that she sets on curling irons as a habit. Well, people don't set up here. They set down here. And so it's not consistent with the story. And the burn is too even and the depth is too even. And this was a curling iron, but it was an intentional burn with a curling iron. The sock pattern that I told you about is this one. This was immersed in hot water. And you can see that pattern right here where there's a perfect line around the ankle, and you see a perfect line around the wrist. And with wrists, you'll see areas in their palms that are spared because they made fists to protect their palms. And sometimes the bottoms of the feet won't be burned as bad because they were held down and there was no hot water to get underneath them. If you see this, this is intentional. You report this. So how do you estimate the size of the burn? Well, we use rule of nines, or rule of palm, which is from the tip of your fingers to the bottom of your palm. That's 1%. Even a baby's hand is 1% for them. But rules of 9 can be a little inaccurate in children because they change. But it's an important factor in getting that first approximation of the burn size for resuscitation. So this is the rules of 9 for an adult. The whole entire head is 9%, the whole entire arm is 9, the whole entire leg is 18, the front is 18, the back is 18, the groin is 1. That all equals 100. This is a good thing to use in the field for estimating your percentage. Or the rule of palm is also. But you can see with kids, in an infant, the head is twice the size of an adult because of that body surface area. And kids don't reach an adult pattern until they're about 15 years old. So there are things out there that you can look at to guesstimate the percentage on a kid's burn depending on their age. It's not their size, it's their age that changes that that body surface area over time for a kid. So that's why it can be inaccurate with the rule of nines. We want to maintain perfusion and organ function when we're doing fluid resuscitation. A doctor told this story. This is the best description I had of the difference between burn and trauma resuscitation. You got 2 tin cans. One tin can has a big hole in it. That's your trauma patient, because the trauma is the hole, and you patch up the hole and you fill it back up. And the burn patient is a tin can full of 100 little holes that you can't patch all those little holes. That's the capillary leak that happens with burns. So rather than patch the holes, we use these formulas to keep the vascular space filled with fluid so that it doesn't affect their pump. So we can keep their COs up, and we can keep their mean arterial pressures at above 60 or 65 to keep everything perfused. So that's the difference. We think of a 1 hole in a can or 1 million holes in a can. Those are your burn patient, trauma patients. But we don't want to give too much or too little fluid, because that also has problems. Kids are sensitive to too much fluid, as well as older adults and people with bad cardiac problems, because they do get compromised quicker. They fill up with fluid faster, and you can have these kids that are with flash pulmonary edema, and that's bad. And you also can have problems with compartment syndrome. And I'll tell you right now, I've only seen one person survive abdominal compartment syndrome, and that was a kid. But usually that doesn't happen, that they survive abdominal compartment syndrome. And it also like it says here, can compromise the delivery of nutrients, which is extremely important in burn wound care to get the burns to heal. The dietitian and stuff works on these to make sure they got enough fuel and stuff to heal their burns. Not enough resuscitation fluid, well, shock, renal failure, which is very common if they don't have a fluid. And if that happens, then they're going to start, other organs are going to start failing. And then you have to start giving them larger volumes of fluid to try and catch up. And when you're trying to catch up, you can have all sorts of different things happen with trying to catch up with over and under resuscitation. You want to get IV access as early as you can. It is okay to go through burned skin to put in an IV, but tape won't stick to burn tissue. So, you know, Coban works really good, Curlex works really good, but you got to monitor that site all the time to make sure that as they swell up, that Coban and Curlex and stuff isn't acting like a tourniquet. Even a 30-minute delay can result in shock, especially in kids, because their fluid status changes a lot quicker than an adult. In large burns, 2 IV sites may be necessary. And you always know you can find an IV somewhere. And with kids or even adults, you can also use IO. But we have had patients, especially adults, that swelled up so much that the IO actually pulled out of the bone from the body, from the tissue swelling up so much. So we'll generally switch them over to a central line when they get to the burn unit. But in the field and stuff, IOs are perfectly fine to get fluids into them. Kids are prone to shock because of, like I said earlier, they lose fluid quicker than an adult. A 10-kilogram kid with a 20% burn can have a loss of about 475 millimeters of fluid. And the problem is that's 60% of their circulating volume. That same size burn in a 70-kilogram adult is 20% of their circulating volume. So kids go into shock quicker because it doesn't take as much fluid loss to send them into shock as it does for an adult. So there's, you know, like that's like my slide says, kids are not just little adults. They're their own specialized little creatures. Now, if you're in the field or anywhere else and you want to just get the fluid started, this is what you can do. This is the initial rate. So for 5 years old and younger, start their fluid at 125 mils an hour. 6 to 13, 250 mils an hour, and 14 and over, which we consider adults in the burn world, 500 mils an hour. Now, we recommend lactated rainers. Sean, are all crews carrying LR these days, or are some still carrying only NS? Do you know?
It'd be, you know, agency specific. Right now, it's hard to get.
What's that?
Right now, it's hard to get either with supply chain issues, but probably depends on the agency. I know we're carrying all LR with
Okay.
NS just in case we have a renal failure.
I know we just had a thing come out at the hospital. Now there's a shortage of NS. So, but with NS, it's okay to use a liter or two, but let us know what you use. Keep track of the type and amount of fluid you put in, and if they have any urine output, keep track of that. That's real important for us. But normal saline dissociates to the point where if they're acidotic, the hydrogen and the chloride hook up and they go into hydrochloric acidosis, where they don't do that with LR, and LR mimics intravascular fluid. Now, you might have a patient, if you do transport, if you're transporting a kid under 30 kilograms, you might see another bag, a second bag of D5LR hanging, which is a maintenance fluid to keep their sugars up, because kids lose their sugars quicker than adults. And that's, the doctors will use what's called the 4-2-1 formula. I'm not going to go into it because you don't have to figure it. It takes too much time. But if you see a D5LR hanging next to the LR, this is maintenance. The D5LR, the plain LR is the titrated fluid for urine output. And then here is what is now called modified Parkland formula. So for adults, 14 and over, instead of the number 4, we use the number 2 times their weight in kilograms times percent body surface area burned. And if it's a 50% burn, you use the number 50, not the number, not 0.5. It's always a whole number. In kids, because kids do lose more fluid than adults do, it's 3 mils times their weight in kilo times percent body burn. And for all electrical injuries, all ages, because of hidden damage, it's 4 times the weight in kilograms times percent body burn. And when I'm talking electrical injuries, it's not flash injuries that you worry about, the hidden damage, it's the contact injuries that you worry about with hidden damage. And once again, if they're under 30 kilos, a kid, they'll have that D5LR hanging. So let's take an adult to do our math here, because I know the answer to this question. So you have a 80 kilogram adult that's had an electrical injury, and it's 50% of their body. So I take 4 times 80 times 50, that equals 16,000, 16 liters. And that's what I'm supposed to give that person over the first 24 hours. I take that number and I split it in half. And half of 16 is 8 in this scenario. And I give that first 8 liters over the first 8 hours. So I start that person at 1 liter an hour. That's just a starting point. Then they'll get someplace where they're going to get a Foley put in them. And they'll take that Foley, put it in, measure that urine and dump it and start their clock at 0. And then in an hour, on an adult, they want to see 30 to 50 mils of urine. And on a kid under 30 kilos, 1 mil per kilo per hour. And on an infant, 2 mils per kilo per hour. Now, since it's an electrical injury, if they have myoglobinuria, if they have rhabdo, where their urine's kind of that reddish brown color, then this becomes 75 to 100 for an adult, and this becomes 2 for a kid. So you kind of double the number, keep their kidneys flushed out to keep those hemochromogens from blocking up their kidneys and causing kidney failure. But let's say their urine looks perfectly fine. So I want to see 30 to 50 mils of urine in an hour out on this adult. After an hour, if they're making more than they're supposed to, so let's use a kid. Let's say we got a 20 kilo kid. So we want to see 20 mils of urine an hour. After an hour, if that kid's making more than 20 mils of urine, I'm going to turn their fluid down by 1/3. And if they're making less, I'm going to turn them up by 1/3. And then I'm going to check it again in an hour. And if they're still making more urine than they're supposed to, I'm going to turn them down by another 1/3. And if they're still making less, I'm going to turn them up by another 1/3. That's fluid resuscitation before they get to the burn unit. We go by urine output, and we titrate the fluids that way. The D5LR, though, remember, the maintenance fluid stays where it's at because you don't want to titrate D5LR because you're going to make their sugars go all over the place. Get all their clothing off to stop the burning process. Get everything covered up with clean, dry sheets. It's especially essential in young kids and older adults because they lose heat quicker. And topical medicines are really not indicated before transport. Now, we will put what they need on them before they get there. If you want to put Xeroform on them to keep things from sticking to them, that's fine. Sometimes our docs will tell the other doc that's transporting to us, this is what you do. This is what you put on before you send them. Other than that, just a clean, dry, warm blanket or whatever you've got and keep them just clean, warm, and dry on transport. Children a lot of times won't complain of pain, and this is another thing with child abuse. Kids that have been abused, if you've ever dealt with it, you'll know you can stick that kid with a needle and they won't complain of pain. They're kind of conditioned. It's kind of sad, but kids usually don't complain of pain. Morphine or fentanyl, whatever you use in your agency for kids is what you use for pain control. And kids also respond well to distraction for pain stuff. We actually use virtual reality in the burn unit, and we use distraction therapy. And a lot of times that stuff works just as well as giving them a narcotic to help to decrease the chance of them being in a lot of pain. Use family members to help provide comfort and support if it's not a child abuse type thing. And ask them for guidance for the kid. What works best for them? Do they have a favorite toy or something that can hold on to that'll help? Of course, you're going to have to also worry about high emotions with families. You know, oh my God, my kid was burned. Think about it as a parent, how you would feel if something happened to your kid. You may actually have to separate the family from the kid for a short time if the parents are just totally freaking out, because that affects the child also. So there's that chance that might have to happen. It's hard to do, but you might have to do that. get a hold of the burn center. Any kid with a burn greater than 10% body surface area that's partial thickness or deeper. Any burns that involve the hands, face, feet, genitals, or major joints. Electrical, chemical, and inhalation injuries. Anytime you suspect child abuse. If you have children with other injuries, call the burn center. If they have a big trauma and a little burn, you want to go to a trauma center. Big burn, little trauma, go to a burn center. At Emmanuel, we have both things on the same campus. And the other burn centers in our region, in Seattle, Salt Lake, and Sacramento, which are the closest ones to us, have the same thing, trauma and burn on the same campus. Verified burn centers and level 1 trauma centers. So we got really good things out there to make sure that kids can get to the right place and have all this stuff treated. How do you refer to the burn center? Well, if you're in the Portland metro area, you're probably going to come to Emmanuel to our ER, and then we're going to have the kids come over to us or to Randall's. Kids that are really, really bad, kids that need to be in intensive care will go to Randall's intensive care, and we'll do the burn care, and they'll do the intensive care part. But there's also that chance that they may need to stop at another hospital. So you always go to the nearest hospital first. So where you're at over there in Eastern Oregon, if you're in Pendleton or LeGrand or anywhere else over there, Baker City, you're going to go to the nearest hospital there. They're going to call us. They're going to send us pictures. We're going to see if they need to transport. I've heard just recently that a lot of the smaller areas, I'm from Madras, so I'm from a smaller area, and you don't have the surface vehicles that can go out of service to go from where you're at to Portland, because we're taking one of your ambulances out of service for up to 12 hours. So I understand that a lot of these patients are now being transported by air, and that's expensive, but it's needed. And LifeFlight, Airlink, and Mercy Flights, and all those guys, they do great jobs. So inform us, we'll see if they really need to come to us or not, or if they can be treated there. And if it's an outpatient, they may come to our outpatient clinic, and our patient folks might tell you how to do outpatient care there in your own facility or in your own area. But if you're more than an hour, you're going to consider air transport. Less than an hour, you're going to come by ground. And in summary, burns and traumas have high mortality rates, plain and simple. Those mortality rates are going down all the time, though, because of the advancements we've made in emergency medicine and in burn care and trauma care. You folks are doing amazing stuff out there. I tell my nurses, when they get to the hospitals alive, it's because of what you folks did in the field. And I wish every nursing school in the state would have their nursing students spend a day with EMS riding along with you to understand what it is you do and understand you're not just ambulance drivers. You're the #1 people out there starting that road to recovery right there from the very beginning. My hat is off to anybody who works in EMS. I could not do what you do because you see the stuff that I don't see. You folks that had to respond to that accident up there by Meacham last week with 170 cars. Wow. That must have been hard. That had to have been difficult. And have 71 patients all of a sudden hitting your hospitals over there in Eastern Oregon must have been overwhelming. Airway, 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 breathing, circulation. Without an airway, nothing else matters. And it's burn wound assessment. That's done in the secondary survey. All I need to know about in the primary survey is what's partial thickness or deeper, greater than 10% to get their fluids going. In the secondary survey, I can learn everything else I need to know. And always, 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 always be aware of child abuse. You're required reporters. We got to keep these kids protected. Does anybody have any questions for me? Thank you very, very much.
All right, here's your chance. If you want to, please, in the chat feature, type any questions you have for Curtis. If you have no questions, you can leave and go to the next link for the next session. But if anybody has any questions, go ahead and type them in now. No questions, Curtis. Covered it all. There's nothing.
Yeah, we all left early. So
we started off with 200, but there's 3 left. So I think that's pretty good.
Okay. Well, Sean, thank you so much. Liz, thank you all. Thank you also for inviting me to do this. I saw your post about the puppy this morning on Facebook. I'm so sorry. But thank you all. Have a great weekend. Have a good conference. I wish I could see you all in person.
Hopefully next year.
Yeah, hopefully next year. So,
All right.
okay, thanks everybody. We'll see
Thanks.
ya. Thanks.